Well, good morning, everyone. Let me wait just another minute. People are still signing on, but the good news is I think we're at quorum. We're a little over quorum, so we're good. But let me wait for another minute and then we'll go ahead and get started. All right, why don't we go ahead and get started? Let me start with the roll call. Again, first, it's great to see everyone. It's good to see that you're able to take time out of your busy schedule to be here today. But let me go through the official roll call. Starting with Baylor, Dr. Goodman. I haven't seen him yet.
I don't think he's coming. It's Yom Kippur.
Okay. And Dr. Williams, you're here?
Present.
From A&M, Dr. Liberzon?
I'm here.
Okay. And Dr. Harper?
Here.
From Texas Tech, Dr. Wakefield?
Here.
And Dr. Trevino?
I'm here.
Okay, great. And then from Texas Tech, El Paso, Dr. Thompson?
Morning, I'm here.
Okay. And Dr. Martin?
Here.
Great. And then from University of North Texas Health Science Center, Dr. Podolwitz. Haven't seen him yet. And then Dr. Chassé.
Present.
Okay. From UT Austin Dell Medical School, Dr. Nimroff. Okay. And Dr. Strakowski.
Yeah, here.
Okay. From A&M, excuse me, not from A&M, from MD Anderson, Dr. Tan and Dr. Robert. From UTMB, Dr. Wagner.
Here.
And Dr. Vo.
Here.
From Houston, UT Health Science Center, Houston, Dr. Suarez.
Here.
And Dr. Newland.
Here.
Great. From UT Health Science Center, San Antonio, Dr. Plitzka.
I'm here.
Perfect. And Dr. Blader.
Here.
From UTRGV, Dr. Escamilla. Michael, are you here? And Michael Patriarca.
I'm here.
Okay. From UT Health Science Center in Tyler, Jeffrey Matthews.
I'm here.
Okay. And Brittany Nichols.
Here.
Okay. From UT Southwestern, Dr. Taminga.
I'm here.
And Dr. Ibrahim.
I'm here.
Okay. From the Health and Human Services Commission, Sonia Gaines.
Here.
And Mike Maples. Okay. From the Higher Education Coordinating Board, Stacy Silverman, Dr. Silverman. And then Danelle Wesley, Miss Wesley.
Here.
Okay. And then from Meadows, Andy Keller.
I'm here for Andy, Dr. Lakey.
And then from the Hogg Foundation, Octavia Martinez.
Present.
And from the Texas Mental Health Council, Danette Castle.
Here?
Okay, and then I'm here, and then Dr. Borges. Okay. And we have quorum.
This is Potter Wiltz. I'm here.
Hey, Alan. Good to know you're here. All right, let me check your box. Anybody else that didn't identify themselves? All right.
26.
We're at 26, well above quorum, so we'll go ahead and get started. Again, thank you all for your time. We have until 3 o'clock, but I think we can probably be done before then. The major things that we're going to do today is get an update on the different projects, which I think that'll go pretty quickly. Get an update on the COSH, and then think through budget reallocations and finalizing the budget for the next year. So why don't we go ahead and get started? The first item of business, we need to approve the minutes from the last meeting. Is there?
Move to approve.
Second.
I have a motion from Alan Polowitz and a second from somebody. Who seconded it?
I seconded. Ibrahim.
Ibrahim. Any further discussion? Hearing none, all in favor of approving the minutes from the last meeting, signify by saying aye.
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 Opposed, nay. Motion passes. So now let's get into the updates from the different components of the consortium, starting off with the communication and marketing strategy. Daniel, Daniel Oppenheimer, are you there?
Yeah, you can call me Dr. Oppenheimer if you want,
All
though.
right,
I haven't earned it.
Yeah.
I can't, somebody needs to enable screen sharing just so I can show. I don't know who's on that. If not, I can verbally give it, but.
Just 1 second, I'll do that.
Okay.
Done.
Okay. Few things I'll just go through quickly. I just wanted to show you on the website, we posted at the bottom a link to a panel, Healthier Texas Summit Series panel. That's a different project that our Office of Population Health is involved with that was recently held, featuring a number of people from our executive committee and Luann. And so if you go to our website and just click on that, it'll take you over to a YouTube video of that if people are interested. Also, just a reminder that the URL on our website is different. The old one will bounce over to this, and any documents that you have links to just are still existing in their same place, but this is now the URL of the consortium site. I don't know if Laurel is going to talk about this later, but I just wanted to, there's a video that her team produced, and I'll put the URL. I just uploaded it to our YouTube channel. It doesn't have some of the summary text, so I haven't made it visible to the public yet, but this link that I can share with people in a second, if people want to watch it, now or later or after Laurel talks about it. I wanted to show folks, we designed some folders, pocket folders, if you can't see the inside here, but there's kind of two varieties of them. There's the happy kids and then the more cool abstract version. So those designs are available, and we can help you if you want to print any of those. We can help you with that. And then I wanted to show, and I'll put this link as well. We're working on the main project that we're working on is the next iteration of the website. So we have some initial designs, and this is a kind of clickable. This isn't an actual website; it's a clickable prototype. But I'll share the URL with folks, and I can just walk through it really quickly. The prototype is a little bit, in terms of dealing with the navigation, it's a little bit tricky. You just need to click off and then hover over to get these drop downs. But it works to the extent that, so you can see there's kind of an about section here. This is a draft of the front page. Links over to CPAN and TChat, resources for parents and guardians. This is sort of new content. I'll just show you a few of these pages. I won't go through all of them, but there's now a dedicated page for the main diagnoses that we're dealing with. So there's text, overall sort of general text on depression. links to screening tools for providers, clinical guidelines for providers, new material, again, a link to that, resources for parents and guardians. So there'll be one of those for depression, anxiety, ADHD. If you go over to the Learn page, there'll be some content on research, resources, a news feed, which will just be sort of press releases and things like that. And a lot of this content exists currently on the current iteration of the website, but a lot of the stuff on the specific diagnoses and materials for providers is going to be new. So we're continuing to work on that, and I'll share. It's a little hard for me to put things in the chat while I'm sharing my screen, but I'll share that in a second, and you guys can kind of bounce around on that. And let me stop my share, and I'll put those URLs in the chat function. So happy to answer any questions, but that's what we're working on.
And Daniel, when does that website go live again?
The new one, that's a little bit TBD. Probably that might be 2 or 3 months before we're able to sort of, we can put some of that content up that on the current iteration that's more urgent to have up, but it's going to take a little while to just code and execute that website. So, I mean, definitely by the end of the calendar year, but I'll be able to give you a more kind of specific timeline after we've really gotten into the guts.
And
So
so
Dan,
Yeah.
if you could add into that list of childhood conditions, if you could add childhood trauma in there, then all of the research programs would be could slot in under your list.
So let me let Laurel respond to that, because I think the reason that I had those conditions was she had folks developing resources for those specific 3. There's absolutely no reason we can't put childhood trauma on. We would just want to have some kind of comparable resources, for childhood trauma before we add that. So as long as there's somebody to provide that to me, I'm happy to put.
We're willing to provide anything. Just,
Okay.
If Laura has some suggestions.
Yes. So, yeah. So Dan's team has been helping us with CPAN. So what we've done is we've modeled our eventual website for CPAN to have, educational materials that would be for providers, families. And we started with sort of our top 3, depression, anxiety. We had work groups that split off to look at those topics and decide sort of what sort of information we'd want to put as our first set of informations on CPAN. And that's why those were the 3 the sort of high yield ones. Certainly we can have another group kind of look at that. And what we did after everybody did their small groups is everybody in the CPAN group reviewed the information so that we all kind of said, yes, we agree, this is information that we all feel would be accurate and could be up on the state website. And again, as we work with Dan's team, we will fill out that website more and more with, hopefully additional educational tools and materials, explaining CPAN, explaining, presenting everybody the teams across the state of Texas. We did have a video created that we hope is informational and will be on the website. I would be fine with it being shared now. Actually, the way that my computer is connected, I'm actually thinking it would be harder for me to share it through my computer. So if it's possible to share it right now, we could do that.
Sorry, I just put that in there and I realized I accidentally only sent it to Dr. Strakowski. So hold on a sec. Let me send it to everyone. Yeah. Hold on.
you can show it now, Daniel.
What?
Laura, you want him to show that video now?
Well, I will try. I don't actually know what the trick is for somebody to be able to see. You guys know that I should know this with Zoom, but you can see what's on my screen, but I don't know. How do you make it so that you can hear it?
There's a click box at the top when you say share, and it says share computer audio.
All right, hold on a sec. Oh, share computer sound. I see what you're saying. Okay. Optimize. Oh, I can even optimize screen sharing for video clip. Okay, so you want me to show this video now?
Yeah, why don't we go ahead and show it now?
Okay. All right. Can you guys see my screen again?
Yes.
All right. So The audio does not always sync with the video when I've noticed when people do the screen sharing, but I've given the YouTube link so people can watch it offline on their own.
My name is Noon Tran. I'm a developmental behavioral pediatrician and co-chair of the Committee on Mental Health for the Texas Pediatric Society, which is the Texas chapter of the American Academy of Pediatrics. I'm excited to tell you about a new program available for all primary care providers in Texas. Just like you, I see many children and adolescents with behavioral or mental health problems, and probably like you, I'm not always sure how to help. Is what I'm hearing normal? Should I refer, and to whom? I don't always want to refer because I've known some of these patients for years. And even if I could, is this something I can manage on my own? It's a sobering fact that 1 in 5 children have a mental health disorder and often cannot get timely access to care for many reasons. Fortunately, our state took action. It's called the Child Psychiatry Access Network, or CPAN. This model of off-site collaboration between primary care and behavioral health is not a new idea. It's been tested and proven to work in over 35 other states. So I'm confident this service will work for our patients and families. Now, you and I have behavioral health folks no matter where we are in Texas to speak to when we have a kiddo in our office who needs our help. Have I piqued your curiosity? Well, let me turn it over to my colleague and good friend, Dr. Laura Williams, the Medical Director of CPAN.
Thanks, Jen. Here at CPAN, you can expect a team of mental health professionals ready to take your call Monday through Friday, 8 to 5 p.m. Across Texas, we have 12 regional hubs employed through the medical school departments of psychiatry. You can rest easy that the teams are well qualified and will provide you with the most up-to-date treatment recommendations. We like to say it's 1 phone call, but 3 services. It's easy because we know how busy you are. You can expect a phone call back within 5 minutes for the first 2 services and within 30 minutes for the 3rd service. Service 1. Our team will help you find improved mental health referrals for the families in your care. Service 2. Our team can help you learn to develop and implement behavioral plans for common emotional and mental health disorders such as sleep issues, school refusal, and other anxieties or worries. Service 3. Our team includes child psychiatrists who are ready to help you in making a diagnosis, developing a treatment plan, and implementing that plan from top to bottom. No question is too small. Give us a call. We're here to help. Call 1-888-901-CPAN. Together, we can help kids build resilience and improve their outcomes. CPAN is here for you and for the families that you care for. Be well.
That's fabulous.
Daniel, did you say where that YouTube link was? Did you?
I think it's now in the chat. Do folks see that? And I need to add some stuff, just description of it. But right now you can see it's just visible to you if you have that that link. And then let me also put in to everyone the clickable prototype for the website.
It does look great. Very nicely done.
And then at the end, Daniel, it looks like the version I saw, it clicks through everyone's logo, right? And so
I stopped it a second before it got to that, but yeah.
So everyone's logo then what would be shown as part of that. And then I guess my other comment is on the website. You'll notice that there's some areas that need information filled in. And so there's some holding icons and language that isn't in English. It's in a make-believe language. That's
right.
People like Daniel do when they create these websites. So just be aware of that.
Right.
That's just holding that block open for when the real language and photos get put in.
Yep, that's right. Yeah, it's just dummy text. So imagine actual, screening tools for providers, which in the case of like the diagnoses, folks have provided. It wasn't worth our time to fill in all that right now when we're just trying to figure out the navigation and the structure.
Yeah, so I want to thank Dr. Tran. Again, we thought it was important to actually start out with the pediatrician introducing CPAN. So I'm very happy. She drove down from Austin to Houston to help make the video. And yes, when you see the video, everybody's logos are on the very end of it, so that it shows how the entire state of Texas and all the HRIs are involved.
All right. Any other questions for Daniel? All right. Steve Pliska, it looks like you're talking, but you're on mute.
I was just wondering who did the guitar riff. It's very good.
I don't know.
All right.
I thought maybe that was Dr. Lakey doing the guitar there.
No. No. All right. Very good. Why don't we move forward? Thank you, Daniel, for the update. I think the video looks really good. And again, we need to thank Dr. Tran for her work in doing that. Let's go now to the program evaluation, and Dr. Lopez, give us an update.
Sure, certainly. I just have three quick things to let you guys know about this time. First, I wanted to introduce that we're going to have a new team member joining us a little bit later this week. His name is David Lynch. So he'll be joining Tracy and I. Some of you may know him. He is a very recent retiree from Health and Human Services. So we're excited to have him join our team. You'll be getting to meet him soon. The second one is that we are preparing to do some qualitative interviews. So we wanted to let you know that was getting ready to happen. These are going to be brief. We know your time is very limited, so we are aiming for no more than 30 minutes. But really our aim is to try to capture some of the accomplishments that have happened in year one as you all have stood up these various programs. We want to capture that for some of the initial documentation. We will be sending out a sign up time to pick a convenient time for you all to do a Zoom or phone interview. And we will aim for the executive management team, but if you have other colleagues that you think would benefit from being a part of that and sharing some of the information about what's happening within your HRI, we welcome you to share that link as well and have them sign up as well. We're going to also gather a little bit of information about your perceptions of how the process is going, decision making, and sort of the overall governance structure. And then my third update is that we are also looking fairly soon to send you all a survey that will capture some elements from our year one in terms of the data metrics. This is not going to be the ongoing way that we will collect information on the data metrics. As you all know, we're working on a number of different strategies to get those embedded in the systems and make it easier. But for this first year, we do have a few of those elements that are being gathered, but we don't yet have a mechanism for you all to share those. So that will come out in two different ways. The actual survey itself will be a Qualtrics survey, so it'll be a fillable link, but we'll also send it to you in a Word format. So if you need to send it to colleagues to fill in particular pieces and make sure you have all the information kind of readily available to submit it, then we'll send it in that way too, just to make it a little bit easier. That survey needs a couple of other eyes on it before we send it out, but we're hoping to do that pretty soon. So you all can share with us some of the accomplishments from year one, and we can have that captured as well now that we've hit the end of the fiscal year. Those are all of my updates, but if anybody has any questions on those or comments on those processes, happy to handle those.
Very good. Any questions for Molly, for Dr. Lopez? All right, seeing none. Thank you again, Dr. Lopez, for being part of our team. Again, Molly's team is our internal evaluation. They're really part of our team. We can have ongoing dialogue and you know, I kind of think of it as kind of quality improvement and as part of the evaluation to make sure we're moving forward. But from the beginning, we decided that we wanted an external evaluator too that has an arm's length away from us, very different roles and responsibility. And Nagla is going to give us an update on the process of selecting that external evaluator.
Thank you, Dr. Lakey. So we have completed kind of the process of getting in all the applications, and we've completed the review process. And where it is right now is in the process of doing all the follow-ups, questions back to the submitters. And we are thinking that within the next week to 2 weeks, there should be an announcement of who got this contract. and we will let everybody know at that time. We should have the entity that got this contract available to speak at our next meeting in October, sorry. So we're on track. We are also at the same time in parallel building up the contract with that entity in order to move forward. Hopefully they will be on board in October.
Any questions for Nagwa? Seeing none, let's go ahead and move forward. And we're going to go through the different projects now. Dr. Plitzka, let's start off with you with the psychiatric community workforce expansion.
Okay, there's not any major update. I was going to ask Sonia Gaines if with the process for HHSC to kind of extract those particular metrics that, you know, the number of patients seen, number of unique visits. Sonia, do you know where that process is?
We're actually running it through, we have the data. The issue is, and Dr. Lakey, you worked at HHSC or, you know, at the state, we have to make sure that our legal team is okay with us basically sending that out. I think we had gotten the list of the D list of where you want that information to go to. Is that correct, Steve?
Yeah, I believe each HRI was asked to designate the people that wanted to receive the information in addition to the COSH and the central people.
Yeah. The good news is that we're not having any problems at all getting the data. It's about, you know, within the next couple of weeks, I should have an answer on, you know, can I just send that straight to you guys, or is there some other kind of process that we have to go through? But we're pretty confident there won't be any problems with this. Just helping people to understand, you know, what the structure is and what our relationship is.
And I'll be working with Laurel going forward on the aspects of what changes need to be made to TRAYT so we can use it in CPW. So I don't anticipate needing to pull the work group together at this point, since we largely have basically administrative tasks to complete. But of course, any of the CPW work group members that think of issues that we need to discuss as a group, you know, let me know. I'm always open to scheduling a meeting if need be. But if you haven't heard from me, it's because we haven't had anything come up that really needed the deliberation of the entire group.
Okay.
That's my report.
Very good. Any questions for Steve?
I actually had a question. Is it being pulled by the attending or by the trainee? And is it being pulled by the schedule or by billing data?
I'll have to get back with you on that in terms of how they're pulling it. And I'll just make sure that that information is included on the bottom of the report.
Yeah, my understanding is they're pulling it. Each resident has a provider number within whatever LMHA they have or they're in, and they've got a process by which to identify them as someone who's is a resident in CPW so that the data can be pulled out. So and I think they're doing the same thing with the attending in the event the attending sees a patient on their own.
I'm asking just because we have some residents that are, for example, attached to the LMHA, right? And they might be funded under SB 11 in one of their rotations with one attending, but then they might rotate to another rotation within the same LMHA, not funded under SB 11. So I was just trying to make sure we were accurate.
And I believe that may be a situation unique to Houston. So we may need to do some kind of special analysis of the data for you.
Okay, thank you.
Any other questions? Hearing none, let's move forward. The next item was on the fellowship program. And Dr. Newland, it sounds like there's really nothing new to update individuals on. I guess a general question to the group, you know, this is kind of the season when people are applying, et cetera. And in our meetings before it became the consortium, we kind of got an early tip that there was a need for additional fellowship slots and a lot of people that were interviewing. Any feedback from the group with how that application process for your fellowships are going so far this year? Are there a lot of people that are interested, or is it less active than the years before?
I think there's been an increase in activity a little bit now that basically across the country, all programs were told to interview remotely and nobody is doing in-person interviews, even for local applicants. So there's been, the AdPERT listserv nationally has seen that there is, a little bit more traffic at every institution for interviews. I think most people are thinking that's more to do with the fact that people aren't having to fly. So they're choosing to maybe look at some more programs. We have inconsistent information about, is it actually there's more applicants this year, or is it just easier for people to apply to interview? So we certainly at Baylor have had about a 15% increase in the applications for this year. But again, I can't say that that's at this point true interest in Baylor. More, it's easier to apply.
Okay. Steve?
We similarly have had plenty of interest. I don't have the exact numbers, but our training director is not concerned about being able to fill the slots. We're going to be adding one part of CPWE. We recruited a faculty to start in July, so we'll be able to add slots for our rural LMHAs in July. So we'll be having 6 people at each level of our residency, and all looks good as far as filling all those slots.
Okay. Dr. Wagner?
More interest than prior years in child, and very much in adult interest, just at least within the medical school.
Okay. All right, very good. All right. Any other questions? If not, let me move forward. I guess let me stop for a second. I think a couple of our executive committee members have joined us since we started. Dr. Borges, I see that you're here,
yeah.
Right? Very
yeah.
good. And Dr. Nimroff, are you here?
I am.
All right, very good. Anybody else that has joined us since we started? I need to recognize. All right, hearing none, let's go ahead and move forward. The next couple items here on TChat and then on CPAN. Dr. Williams, I don't know if you want to, and Dr. Wakefield, give any specific updates here versus the overall COSH update in just a little bit. Actually, with Dr. Wakefield, let me start off with you. Anything besides that update that we need to talk about on TChat?
No, I don't think so.
Okay, very good. And Dr. Williams, the same. I think we can just kind of fold your update into the overall COSH update. Very good. And then we had an item related to the metrics for the consortium initiatives. We talked a little bit about that on the CPWE just a little bit ago, but Dr. Pliska, is there any other part of that items related to metrics that we need to discuss? I had your name down on that item. Okay. You're muted. But I read your lips and I think you said no.
No, it's just a matter of executing the elements that we approved last meeting.
Okay, very good. So then let's go to the research initiative, Dr. Taminga.
The research, there's 2 research groups, as you know. There's one focused on childhood depression and the other one focused on childhood trauma. And that's why I wanted a piece around childhood trauma included in the material that Laura wrote, and we can get that done for you, Laura. Both groups, there are 12 sites in both networks, and all the networks are, as far as I know, trained and ready to start. The IRB is currently the limiting factor. Many, but not all of the sites are currently IRB approved. And the IRB is working steadily with all of the sites to get approved. Once all the IRB approved, every site that gets IRB approved will be able to start collecting people within the network. So there's about half of all the sites that are approved in each network. For the most part, all the sites have been quite diligent. Of course, there are a few laggers, but we'll put extra work into that and move those all along. Anything specific, David?
Nope, just want to make sure. Maybe let's go to Dr. Nemiroff and then to Dr. Trivedi and just hear from them if there's anything that they need to tell us. Dr. Nemiroff?
We're very excited about launching the trauma network, and we're actually starting to recruit patients today here in Austin. And as I think Carol gave a good summary, so there's a lot of steps that have to be taken. Almost all of the nodes have participated in the training. There are only a couple of nodes who've not had the requisite training for their RAs, and we're addressing that. Once the IRB is approved locally, and that's a negotiation between UT Southwestern and the local IRB, then we should be ready to launch. I'm not going to bore you with the 6 or 7 steps that each node has to take in order to be approved. But we're very excited, and we'll be collecting subjects momentarily.
All right, very good. Any questions for Dr. Nemiroff? All right, Dr. Trivedi, anything you want to update the group on? Dr. Trivedi, are you still with us? I don't see Dr. Trivedi here right now. So I think he was here earlier. He may have had to leave. All right. So why don't we go ahead and then move forward with the overall COSH update, and Dr. Williams? Dr. Williams?
I'm getting getting it ready before I share my screen. Oh, there it is. Share. Okay. All right. So this won't take very long. We just want to kind of highlight a couple of things that we've done for the course of the last few months, since this is the end of the reporting year for the state. Next slide. So we're going to talk about the telecommunications, the data management, the CPAN, TChat, and the statewide referral system. This is a boring slide, but it's actually a slide that sort of talks about pretty much all the things that have been done in the last several months. There's been a lot of work across each individual HRI, across the COSH itself, that needed to get accomplished. And I think that the piece I really want to say here is that it really was a collaborative effort. Everybody did, all hands on deck, came together, legal, Luann and Lachelle, the team with Dr. Lakey's team, with the UT compliance officer team, with the vendors that we've selected to work with. So there's just been a lot of work that needed to occur, and I'm happy to say that everybody's pulled their bootstraps up and really got to work. So we've definitely managed to do quite a bit of things. As we know, the Lantana did turn the phone on for us on May 18th. The contract was actually completed in August. we've had to go through a couple of different adjustments about the call directory and how it's going to work. We want it to be easy for a provider when they call the number to get to the correct hub. So we're working on that piece. There is a summary report that you can see. I'm not going to pull it up right now. It's in the materials that were attached for this meeting today, talking about the project. What that basically shows us is step-by-step all the various pieces that needs to happen for us to completely roll over to the Lantana phone system. The goal we have is by end of October that all the HRIs will be stood up and be using Lantana, and Baylor will stop being the switch operator because the Lantana program will be doing it for us. And in that way, we'll be able to collect that data of the number of calls and making sure that we're hitting our first metric, as we saw with the video, that we were making that first phone call back within 5 minutes. So that Baylor is going to get trained on this first next week and start working on it. And then the Lantana team will train a couple of other teams probably per week. And we'll keep circling back and making improvements as needed. But again, the goal is to have it completely up and running by the end of October. Questions there? The next piece of this is the TRAYT. As again, we've been working with them. Their contract also was completed in August. The phase 1 and 2 of CPAN has been completely built out. The phase 3 is that final piece, which is the ability for PCPs to send out tracking to the patient. So remember that this is not CPAN tracking, it's the primary care physician requesting that the patient do tracking. So we're not establishing a relationship with the patient, as well as being able to send out information through TRAYT to the PCP. The training for how to use the TRAYT application for all the teams, I think there's one hub that hadn't gotten their training yet, but we're near completion for everybody to be able to completely move away from the Red Cat system and use TRAYT for the work of CPAN. The TRAYT application for TChat, the plain version that we discussed, will be available this week for people as soon as the joinder agreement is signed. I'll talk about that in, I think, a few minutes. As we talked about, this is just the plain version of TRAYT, what they already do, which is data tracking for patient outcomes. The build, which will include the metrics for the state that are required for us to report, that says they will take them about 6 weeks to do. We are updating our contract with TRAYT to incorporate both TChat and CPWE. There is the possibility that we will use TRAYT for that student screening, which is another way to fold people into TChat if there's a screen positive. And then there's also the goal to potentially have TRAYT do a federated authentication system for all the HRIs that is also to be determined down the road if that budget item gets approved. We did not have a meeting for the data governance team between now and the last time we met. I spoke with Alex, and we're still on that step 3. We're working on a data library. As we suggested, that piece is going to take a couple of months to do. And so I think probably what we'll do is once we get that done, we'll provide that information to you. I don't know if Alex or Dr. Steve wanted to say anything before I moved on from this one.
No, I don't have anything. That's well said.
Okay, great.
Just one comment, small thing. At San Antonio, they were pretty insistent on having federated login be a feature. So, yeah,
right.
As you're trying to negotiate this one way or the other, they're going to want it, especially if we're going to be getting into integration with EMRs and stuff.
Well, we have it possibly in budget. So moving on, so from the cost perspective, we have developed a contract with the Texas Pediatric Society. That's going to allow us to do marketing and communication through collaboration with TPS. So we've talked with them about sending out information via their email listserv about CPAN. They have a very a nice click rate. And what that means is that the PCP pediatricians actually open up mail from TPS. So that's one of the things we're hoping is to actually have eyeballs see information and not just have it go into a trash can. That also allows us to have an opportunity to have a booth at their 2 meetings a year. Obviously, this year in the fall, that meeting is virtual, but potentially maybe by the spring it will be in person. Dr. Tran and I are doing a presentation for TPS also in October discussing CPAN. So we're getting the word out to pediatricians in that sort of statewide COSH way. We have done the ordering. Dan's team has helped us to make sure when we put the educational materials out that it has the logos on in the correct way so that they look good. We're estimating that the arrival of that will happen mid-October. And at that point, COSH will send all the educational materials out to each of the teams. And then depending on how quickly people run through that inventory, we'll probably want to do another big purchase order again sometime in this next fiscal year, maybe with some of the same things, maybe with some different educational materials, but that's getting itself done. As you saw a few minutes ago, we did make that short video that hopefully is friendly, quick, explains what CPAN is. It will be added to the website that Dan's team is working on. And then again, I'm not going to pull the sheet up for you, but we did work on what's a comprehensive communication and marketing outreach strategy for all the HRIs. We've had in our state meetings conversations about how we're going to work towards, the twofold process of both enrolling PCPs into CPAN, but then more importantly, getting them to pick up the phone and call us after they've enrolled. So that strategy is meant to be sort of at minimum what all the HRIs can and should be doing with their staff to help get the word out and engage PCPs. Obviously, HRIs can and should do more, but we think that the strategies that we've put together are very doable strategies and will help get the word out and get the phones ringing, for lack of a better word. So again, you can see that piece of it as well. We've had close to 2,000. Sorry, was there a question?
I was just going to let everybody know that those are 2 of the documents that you received in the packet of information for today is the communication strategy. So you've got those.
Yeah, so yes, they're there for everybody. All the HRIs, I can say that the state, so we have a state meeting once a week for both CPAN, not once a week, once a month, for both CPAN and TCHAT, and we've had great participation. All the HRI teams are coming together. We're sharing information with each other. So COSH has monthly meetings with each HRI separate TCHAT CPAN teams where we talk specifically with those teams about what's going on for them and how to help them. But these state meetings where the teams that we've all come together, it's very productive because it allows us to share information across teams and help us with that measure of, particularly for CPAN consistency. But again, this summary here of the communication strategies, I didn't want to read it out to you, but it's available as Luann suggested. Again, we have close to 2,000 providers registered. That's, again, it's a small amount of PCPs in relation to the larger number total in Texas, but we are steadily making progress there. The calls are picking up, Dr. Lakey. We now have about 7 to 8 calls per day on average. So just in the last few weeks, the number of calls per day, have picked up. Again, my perspective on that, it's really a combination of more teams. So not all the teams were ready to go with CPAN, and now more teams are, and they're starting to do their marketing and outreach to their local hubs. And also PCPs are back in the office. School's back in session, so kids are more likely to be coming and seeing their pediatrician. So I think we're just seeing hopefully a nice sort of confluence of events that will allow us to capitalize on enrollment and engagement. So I do expect that we'll see these numbers continue to keep going up. When you see here, you can look at what type of provider is the PCP asking for help with, and it still is the bulk of the calls are being directed towards the physician, And then when you see the reason for the call, there is, again, a wide variety of reasons, but the bulk of the call reasons are around medications and how to consider managing medications. So it is still more that they're calling for that. We have a couple of providers in Texas that call quite frequently, actually. And one of the things, Molly, we were talking about was whether or not we wanted to engage with some of these early adopters and get their feedback about what's making them interested. So that might be something when you're doing your qualitative that we might see if any of those PCPs that call frequently would be interested in talking with you. But they often call for things beyond med management, particularly trying to help them find better referrals for kids in their area. Again, this question is more based on what does the provider, our psychiatrists, think as far as the complexity of the question being asked. And right now, sort of a majority of them still feel like it's a relatively straightforward question that's being asked, and that the problem that they're calling about is pretty moderate. So, there's definitely severe cases that are being called on, but it's still that kind of mild to moderate, somewhat straightforward sort of question that is being asked. And again, this is based on our perception of it, not the PCP's perception. For those calls, what is recommended? There, as you can see, there's a wide variety of things that can be recommended based on that educational conversation that they have with the PCP. There is actually, not a small amount where there's not a recommendation, meaning that they're not saying that the PCP needs to do something new. So that maybe some of those calls are kind of also reassurance that you are doing the right thing, stay the course. And then when you look at where the referral is being recommended to go to when the PCP calls, there is, again, right now we don't have that level of specificity, but with TRAYT, we will start to have that level, a greater level of specificity of who are those local providers that they are referring to, because that is the bulk of the referrals as they're getting is as some sort of local provider. And we'll have more detail on that hopefully at the next meeting. Dr. Lakey, were you going to say something?
Quick question on that pie chart. The start new medication, does that include changes in medication if you take a person off of one medicine and put them on another, and somebody that was on no medications and you put them on a medicine, or is there a way to kind of divide up those two groups? Does that make sense?
Yeah, it does make sense. So yes, are we adding new but not taking others off? Yeah, so I think that REDCap doesn't do that as well for us, but the TRAYT app will be able to sort of see with more specificity. Again, remember, we're recommending things. So one of the things we're actually going to do with the TRAYT application is if a PCP calls back a second time about the same child, we're actually it's going to prompt us to ask them a question. Did you do any of those recommended things that we discussed last time? Because right now we don't know if the PCP is going to do these things or not. It's in the course of an educational conversation. We say, well, you might want to think about this, you might want to think about that. So we actually think it'll be even more interesting and helpful when the PCP calls back to find out what, if anything, about our recommendations did they decide to do after they spoke with the family.
Okay, very good. I just think it'll be helpful for us as we explain what's going on, dividing up between those two groups, that somebody was already on a medicine and they were not on the right one and we changed it, versus somebody wasn't on any medicines and then we put them on one.
Yes. Good question and good idea. Okay. So that's CPAN. So again, I think we're making progress, and I do expect that we'll continue to get more traffic. TChat, as we agreed last time, we had the statewide agreement on utilizing TRAYT. We had the standardization. This is a summary with things we've already heard. Standardization of the outcome measures we're going to use to follow the young people. All the teams have had to adjust to this concept of families being at home versus being at school. We do think that that's a way for us to maybe actually expand our services and maybe even reach more kids with this process. So most teams are still imagining moving forward that they'll have a hybrid of some of the TChat services will be on campus, and some of the TChat services will continue at a family member's home. all of this is obviously done with parental legal guardian permission. We are working to have each of the local HRIs partner with LMHAs in their area, as well as the TEA regional reps, to really make sure that we're expanding out to as many ISDs as possible, making sure that we're hitting, getting kids as much as possible the service of TCHAT into our rural areas. And so all the HRIs are working with their TEA rep to kind of maybe identify a couple of more ISDs that they may want to partner with in this sort of fall period. And then Dr. Pliska graciously agreed at our last TCHAT meeting to kind of help us create our first draft of kind of a statewide manual. Again, one of the things we have to be careful about is that not everybody is doing TCHAT in the exact same way, but we do think that there's several principles and foundational pieces that we can say across the state we're all kind of employing and doing. And so Dr. Pliska is going to help us. And that will be a group project that all the HRI teams will help in crafting that as a document.
I'd like to add, the HHSC has put out guidelines, and first were the foster care parameters. They've been expanded for kind of guidelines for all children on Medicaid. And I was going to use that as a jumping off point. First off, because it's very good. It's got a lot of good philosophical language in there, which is not overly prescriptive. And also, I think it makes sense for the state of Texas to speak with one voice on this issue. So I'm going to take that and then add some additional guidelines and send that out as the first draft, first to the TCHAT committee, and then I think it'll go out broader beyond that and kind of get people's different ideas together.
Dr. Williams, does Dr. Pliska have access to all of those materials that the TCHAT work group developed for a similar thing? If not, I can send those to you, Dr. Pliska.
Please do.
Okay.
That may make my work even quicker.
Yeah, we developed some things about referral strategies in addition to, and how you can conceptualize that, and also suicide safety monitoring and all of those things. So I'm happy to send those to you.
Very good. And bear in mind, this is really more of our psychopharmacology manual as opposed to we don't want it to be a child psychiatry. So we're not going to, at least my first draft, I won't get into psychosocial interventions for suicide or thing like this. This is going to be a little more narrowly focused on the psychopharm portion. But still, all those other materials, it'll be very useful for me to look at.
Yeah, I think over as we move through this process, I imagine and hope that it will be kind of in totality. But as I said, a lot of the work that we've done over the summer is just agreeing on some basic principles about how TCHAT's going to run. Obviously, teams are working to hire and stand up their teams. We will have at our next meeting, I will start reporting out data as far as number of children served for TCHAT. But again, because many teams were not up and ready to go, and the school year has just started, I thought that we would allow that to be, we'll report out in October information. So all the HRRs are going to start sending us, obviously, de-identified information of the kids that they're serving. So I'll provide that at the next consortium meeting.
Laurel, do you think that the TRAYT implementation for TCHAT is going to be far enough along that those procedures could be incorporated into the psychopharm bit, so that from step one, so to speak, we're implementing measurement-based care?
So step one, so TRAYT already, as part of its just vanilla version, asked what medications you're taking. So it is part of that process, and we would, as the clinicians, we can say yes, they're taking it, no, they're not taking it. So yes, those would be things that the vanilla version could definitely say something about that.
I was thinking more of the outcome monitoring part, to have, especially as new staff come on and you use this manual to train people, that they could see the direct relationship between the data capture from rating scales and assessments and things like that, and what you're actually doing psychopharm-wise.
I'm not sure that October we could have that, but I definitely think probably like by December, because again, we have to get people on and then start using it. And then kids have, you know, those 3 to 4 sessions of care. And so I think, you know, by December, we probably could share some of that information.
Right. Mm-hmm. And I'm happy to work with Steve and contribute whatever I could on the measurement side for these things. So.
That'd be very helpful. So yes, I think that, yeah, so I think that is all. Sorry, I can't. Yeah. So yeah, so for T-Chat, again, the joinder agreement will go out this week for teams to sign. TRAYT has already built the sort of hubs that they need for each of the HRIs. So as soon as they see the joinder agreement is signed, then the teams will get their training on TRAYT and can start using it for this purpose. We are still planning to do a partnership with WellNeti. We are cognizant of that the state is also developing a statewide referral system, so we didn't want to be doing something that was potentially duplication of effort. However, in talking a little bit more about what that system is going to look like, it does still actually make some sense to kind of keep moving forward. This is again, a project or a platform that can help with real-time information. And so we're going to feed in and work closely with the state team that's working on their behavioral health referral system. So at this point, we're still thinking that there is an added advantage and a reason to have that process going. And so we're still planning on moving forward with it, but we are going to do that with close collaboration with the state team. For CPWE, I have reached out now to the HRIs in this last week or two to understand the rotation structure. I think as Liz was sort of alluding to a little while ago, different teams are approaching their CPWE in different ways. Baylor also has a relationship with our local MHA where providers go and do something that's non SB 11 bill related. So I do think that at least one other team will have that issue of making sure that we're not overcounting what's happening as a relationship to this new rotation that's been developed. As Dr. Pliska said, you know, TRAYT can do that platform of the outcomes, but we also want to, again, work in concert with what the state's doing as far as pulling the data, as was suggested earlier from the EMR. So again, we're just going to try our best to work closely with both the state team and then the local HRIs to make sure that we're getting the correct data that we need to get. If it ends up taking more time than anticipated or is not as accurate as we liked, one of the conversations we had was potentially just at the HRI level, having the residents have sort of a simple form that they complete to show how many patients they saw on that particular rotation. So again, we're waiting to see a little bit how long it takes, because we certainly don't want to do that step if it's not needed, because the data could be pulled straight from the EMR. So we're pausing on that to see what sort of data the state says that they can provide just by searching the EMR. So we're starting to work on this piece as well. And then that is all we had today. Like I said, it was just a high-level overview. I knew that we had lots of other things to discuss, so we're done. Thanks, Jennifer.
Very good. Any questions for Dr. Williams?
Dr. Lakey, this is Sonia. One comment and something I thought about as you were going through that we might want to consider. Recently, you know, the coordinating council revamped the mentalhealthtx.org website, resulting in a lot of new bells and whistles that I think could really be helpful in terms of, you know, kind of identifying some of our programs like C-SPAN and T-Chat as a resource that's available. There on that website now, there's a service locator, and all the resources that are fed into 211, all the behavioral health resources are now available when people pull up in their zip code. So Dr. Williams, what I'd like to do is send you some information on how the providers can, make sure that their information is tied to that website. Because I think that could be another source, of referral and information for, for doctors, for teachers, for, the whole 9 yards.
This is brilliant. I would just wanted to pop in and support that I have already shared that with all of our team, and our therapists will definitely be using that as a resource. And also that there have been just a lot of emails in our community going around about what a great kind of one-stop shop to some extent mentalhealthtexas.org is.
Yeah,
awesome.
it's mentalhealthtx.org, and I'll put it in the chat box so everybody can have it. But
thank you.
It just dawned on me that, hey, that's another way that we, capitalizing on infrastructure that already exists and, continuing those partnerships. And 211 is, again, a great resource that everybody knows about already. So
I think that sounds perfect.
We'll do that.
Okay. I'm going to stop sharing, and if there's any other questions, I'll answer.
Any other questions for Dr. Williams?
This is Luann, and I just wanted to acknowledge Dr. Williams and Jennifer and her team at Baylor. This COSH work is a lot. It's very extensive, and a lot has gone into it, and y'all have done a great job of moving things forward. And so I just wanted to acknowledge you. You guys have done a great job.
You're here.
It is encouraging that the numbers are going up. And again, I think we need to remind ourselves that, we didn't let money to the institutions to start this and about 6 months ago, right? And building it up and moving it forward. I think this will be a little bit, you build it, they will come, that we should expect that the volumes should each month continue to go up as we get the news out.
I just want to say that comment about Dr. Williams' performance in the role with the COSH. She is extremely helpful to all of the academic medical centers, and her approach is one that's very open. She's always looking for solutions to make sure that all of the sites are performing well. So really hats off to you, Dr. Williams.
Very good.
I appreciate it. Jennifer is my right and left hand. So we really work as a team. And Luann and Lachelle save my bacon on at least a weekly basis. So it's definitely a team effort. We're having a lot of fun, and the teams are really fantastic. I just hats off to all the HRIs. You've really got a bunch of really dedicated, cool team members that are jazzed to be working. And I think we're going to accomplish a great deal for the kids in Texas. I'm very happy.
Very good.
And I did want to ask one question, because we get asked this sometimes. If you could just, again, update us on the number of school districts that y'all have been working with. I think the last number, as I recall, was and I don't know, I'm hoping I get this right, 138 school districts and approximately 1,300 and some odd schools. Is that about right, or do we have more? Or?
It's about right, but like I said, we've been having both the statewide and individual level stretch goals of adding some additional schools. Just for example, at Baylor, summer was quiet, and again, in child psychiatry, that's normal for things to be a little quiet in the summer. So, and then as Sarah suggested, it has started to creep up. So we're definitely getting more referrals for kids in TChat as school started. We actually get a lot of them on the weekend, so we'll get a dump during the weekend. So on Monday when we show up, there's a list of kids that we need to call to start for services. So I think that we're wanting to go out, and the goal, all the HRIs know that the goal is to add some more ISDs. But we're going to target and really try to help with more of our rural teams and make sure that we're really reaching out beyond sort of the urban borders. I'll get that to you.
Very good. Any other questions or comments? Hearing none, why don't we go ahead and move forward? Actually, let me, before we jump into the budgets, Dr. Trivedi is now on. He had to step away from meeting earlier. Dr. Trivedi, was there anything that you wanted to tell this group related to your research work?
So maybe quick, very quick 2 minutes. So we have launched the, the network. We have UT Southwestern already enrolling. We have 4 participants in the project. 7 sites are very close to getting their IRB approvals. UT Southwestern actually has already approved their IRBs. They now need to get their local IRBs to give their stamp of approval. So our hope is that by the 10th of October, 8 of the 12 will have launched. When we come back next time, we should have a significant number of people already participating. Training and certification and assessor monitoring, et cetera, all that is done. The EDC is functioning, the electronic data capture, et cetera. So, and we have this number of committees. We can give you a report next time. I don't want to take too much time.
All right, very good. Any questions for Dr. Trivedi? Hearing none, let's go ahead and jump into the bulk of the conversation that we need to have today and finalize the budget for the upcoming year. Just to kind of set the stage for this conversation, this will be a summary of a lot of work that has taken place over the last several months. Each of our institutions looked at their budget, their expenditures, their plans, and met with us within our UT system administrative team to talk through their budgets. We've shared what we thought were good ideas across institutions, trying to keep the money in the same buckets with CPAN, TChat, CPWE, et cetera, and maximize the ability of each institution to use their budget, looking at both recurring dollars and one-time dollars. We then, each institution looked at the dollars that could be made available to the group as a whole. At the last meeting, we got some suggestions and went over some suggestions on things that would be good for the state and good for our institutions if there were dollars that were made available. Since that last meeting, we've had a series of meetings again with institutions to making sure that we were finalized on their final budget and to think through these proposals. I think overall, people will be happy. We haven't been able to do everything that people would like, but I think we can do a lot of things that people think would be beneficial to their programs. And again, trying to minimize the amount of money that is shared from one bucket to another. Overall, it looks to me that we've been able to keep those transfers to less than 10%. The importance of that 10% number is that we told the LBB that we would we'd go for them for approval if we needed to shift money more than 10% from one institution to another or from one bucket to another. And I think we've met that threshold of being below 10%. There is a nuance to that in that there's one item that each of our institutions were looking at purchasing, and it made sense for us to do that with an economy of scale and purchase that through the COSH for everyone. And so it looks like the COSH budget is up more than that 10%. But the reality is that was just an efficient way to get things done and standardized versus really transferring dollars out of these buckets that we've outlined. So I'm going to let Michelle walk through this, and then we have ample time to discuss, but just wanted to lay out at a high level kind of that process, which I think has been a rigorous process with all of our institutions to make sure that we're following the rules and using these dollars and being the best stewards we can and are aligned with the legislative intent of the allocation. So now let me hand off to Lachelle, and Lachelle, let you walk us through kind of where we ended up.
Great. Can everybody see my screen okay?
Yes.
Okay, so I'm just going to go through some quick highlights, and then we'll go into the recommendations and each of the individual items that we need to vote on and approve. So in summary, we had about 3.6 million of one-time funds that were available for reallocation after we went through that process of getting revised budgets from each of the HRIs. Of that, 393,000, just a little over, was recurring funds or money that would support ongoing operational costs that would be available for reallocation. When we looked at all of the different proposals that were provided, we had a total of about 2.5 million. And assuming that all of those proposals are approved as we're recommending, that would leave just a little under 1.5 million of funds that would be left unallocated. So assuming that all the proposals are approved, the CPAN budget will decrease by 6%, and the TCHAT budget will decrease by 4%. CPWE was the only budget that increased, that's at 9%, and CAP Fellowships budget will decrease by 4%. I just want to say that this is just for this next fiscal year. We will be asking for additional funds from the LBB to support those new CAP fellowship programs that are being stood up. No guaranteed it'll be approved, but we will be asking. And so that CAP fellowship budget for ongoing years may be higher. This is just a graphic of what our expenditure looks like based on the budgets that were given to us. So as you can see, expenditure in year one, which is the dark blue, was a lot lower than what we're hoping to spend in FY21. That's as a result of us just getting started later in the year and then encountering all the issues that we encountered with hiring and getting these programs stood up during a pandemic. The orange area are the one-time funds, and where we're proposing those get allocated, and the yellow are new recurring funds that are being given to the HRI. So we are recommending that all of the HRI budget changes are approved. And this is a summary at the institution level of what those changes look like. 2 of the institutions are maintaining the same budget that was approved by the LBB. All of the others are being reduced. This is, again, before the proposals have been applied. So Dr. Lakey, I don't know if we want to stop and have everybody have a look and get an approval for each one of these items.
Let's hold here for a minute and let our institutions take a look at this. Again, there are some changes. Most of them are not very big, but you can see 100,000 here or so, less than in other institutions. But this is based, again, on the feedback we got from your institutions, working with you, and trying to make sure we totally understood what those changes were.
Is there any way to make it so we can see that last column? People's pictures are blocking it. I don't know if that's just my screen.
Let me try.
I'm seeing all the columns.
If you click the middle between the screenshot and the pictures, you'll see your cursor turn, and you can shift the screen over a little bit to maximize the presentation.
Ah, okay. Thank you.
Or use the speaker's view.
Okay, sorry, I don't know if that's better or not. This was also sent out. If you need to open up the attachment, you can also see it there.
Okay, thanks.
Okay. So these are the adjustments before any additional dollars are allocated based on the feedback from the institutions working with our teams. I guess maybe, Lachelle, we can take this kind of stepwise and approve each step accordingly. And so with that, is there a motion to approve these changes within the institutional's budgets?
So moved.
I have a motion by Dr. Tominga.
Second.
Second by Alex Vo. Any further discussion?
The only thing I would ask David and Lachelle is if we could have this table, would it be possible for you to just send around to all of the sites this table?
It's in the presentation that was attached that went out this morning, so you should have it there. But if you want the detail behind the table, I'm happy to send that to you.
No, that's all I want. That's so
Okay.
good. Thank you.
Uh-huh.
Sorry, I didn't look.
So we're gonna need to have some other stepwise changes kind of through this presentation. But I have a motion and a second, motion by Dr. Tominga, second by Alex Vo, for these adjustments within the budgets for the next fiscal year. Any further discussion?
And David, do we have the jurisdiction to do this, or does this have to go back to our governing body?
So we would be the governing body for this. If it is above 10%, then we need to go to the LBB. We are below that 10% threshold. So I think it's within our jurisdiction to make this approval and these changes.
Got it. Thanks.
Okay. Any further discussion? Hearing none, all in favor of approving the fiscal year 21 budget based on these numbers signify by saying aye.
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 All opposed signify with nay. Are there anybody that abstains? Okay. So we have unanimous approval for those budgetary changes from the executive committee. Okay. Michelle, let me hand off back over to you.
All right. So on the recurring funds, Dell actually pulled out their request that was there previously. So we were able to fund all three of UTRGV's requests with the existing funds. And those requests were for an additional 0.5 of a faculty FTE for CPW. And there was one additional resident FTE for CPW. And then 0.35 of an FTE child psychiatrist for CPAN.
And so let's combine this with the one-time dollars, because I think they go hand in hand. Okay, because we had recurring dollars, and then we had one-time money that was basically left over from this last year, and we were able to use those one-time dollars, I think, in ways to meet many of the other asks. And I think I just want to make sure everyone knows all the asks that were addressed and can vote on them together. Michael Petrarca, it looked like you were trying to get in. Anything you were trying to say?
Yes, good morning. No, nothing to really add, Dr. Lakey, but these are for incremental recurring funds, as you stated, for each one of these programs, so we are able to kind of increase scope and presence in the Valley. So
yeah. So this would be able to do what will enable UTRGV to do what they had explained to us before on related to providing additional support to local mental health authorities through telemedicine. And basically they now would be able to support, I believe, all the local mental health authorities within their jurisdiction, either in person or through telemedicine. Okay. All right, Lachelle, let's go to the next slide.
All right. So the next recommendation is around the COSH proposals. So as Dr. Lakey mentioned earlier, there were funds that were earmarked within individual HRI budgets for technology, and including data management and telephony, which totaled $811,000 in total. And so we're going to go through each of those COSH additional requests, but by combining those funds that were being taken from the HRI budgets that were not going to be utilized, and then some additional funds, were able to meet that additional request for funds to support some of the new scope being added to the COSH. And those items are outlined here. So we have the TCHATS screening tool for 52,000, additional storage costs related to the additional scope of services, federated authentication development and bundled annual costs. The other hat I wear here at UT System is around information security. I'm a program manager for the department. And so I can reiterate what Dr. Blader was saying, that this is something that we definitely want to include moving forward for just as a technical control on the security aspect. And then build out of referral database and bundled annual costs. Texas Pediatric Society advertising costs, education and outreach tools for CPAN, and the development of CPAN podcast. And Dr. Williams, I don't know if you wanted to add anything here around these costs, but I think we talked through many of them last time. There were a few new ones, but these are all additional items of scope that were not a part of the PIA that was originally put in place for the COSH, and it makes sense to add those costs to them.
So these would be things that benefit all institutions. We would be funneling it through the cost in order to secure these capacities. And again, some additional marketing and additional training on top of that. And using one-time funds that would otherwise lapse, and being able to put these in place for several years in order to provide these services.
Hey, can I ask a quick question regarding the storage costs? Where is TRAYT planning on providing this storage? Is it in the cloud or is it their own servers? And do we have access to it?
Cloud. We have access to it. It's our data.
Okay. Any other questions? Hearing none, Lachelle, why don't you go to the next slide?
So the last recommendation is to approve all other proposals for one-time funds. Those were items that we discussed last time, including the CBT pilot that Baylor was recommending, the development of training models for residents and fellows in EBT that UT Health Science Center San Antonio was recommending, the addition of one CAP fellow to the Dell program, and subcontracting for outreach and engagement consultation. That's a new request that we didn't talk about last time, but that Dell is requesting.
Okay. So those are all the proposals then, right?
Yes.
And so again, a mixture of recurring dollars to meet items that will be ongoing, and then with the one-time funds, we need to complete that this year. And these proposals, we believe we can meet within our budget using those dollars that would otherwise lapse. Okay. Is there
David?
Yes, Carol?
Can I talk a minute? You know, the research group has kind of had a standing request for funding for some special projects related to depression and for trauma. After all of the clinical care requests get filled, if there are any extra dollars that are not needed in clinical care initiatives, I'm just wondering if we could entertain some additional research dollars.
So Carol, the feedback that I've gotten from legislators is I need to be pretty firm on that $10 million that we put into research, and need to be very careful of flowing dollars from the clinical components of the consortium into those research items. We'll have some dollars that are left over. I'm happy to talk to them again, but the feedback again that I've gotten so far is to be very careful with moving dollars from the clinical enterprise into that research enterprise as we go into the next session. Okay?
Sure, we would be very respectful of that for sure, because it's going to reflect on the overall TCMHCC project. If there's any of that $10 million that got repurposed, if it could stay within research projects, that would be very welcome.
All the money from research is still going into research.
Cool.
So there isn't any allocation out of research. And again, I just need to make sure I also don't reallocate out of clinical into research.
We could use the money well, and we would, if it were ever reallocated, you could promise the legislators.
So then, Lachelle, is there, what's on the next slide? Do we have remind me, do we have a summary slide of all the changes?
Yes.
Okay.
So this slide just shows by institution a breakdown of each of the different programs and the dollar changes that we're seeing in each of those programs and what that percent change looks like. As you indicated, the COSH amount looks slightly higher, but actually it was a reallocation of dollars for CPAN and for TCHAT that were being moved to the COSH to help support the centralization of those services. Overall, we're seeing a reduction in budget for most people, even with the increase or the addition of the proposals. I think Dell is one of the outliers. They're a 7% increase, and UT Health San Antonio has a 3% increase, and UTRGV a 6% increase. But overall, most people are actually reducing their budget.
If I may, David?
Yes, Israel.
I was just thinking about what Carol was saying in your response, and what came to mind is that without moving things into research, we do have internal evaluation process. Now, the people who do public health evaluation do understand that part of that, especially for the outcome evaluation, involved RCT designs and stuff like that, that part of actual evaluation process. Now that's where the evaluation and the research have the overlapping goals and even overlapping designs. So I'm wondering whether one can think about increasing, without moving things to the research, increasing some of the budget for evaluation, program evaluation category that will take an advisement from the research group of how to evaluate using RCT design or even quasi-experimental design, particular intervention components of our work.
So David, could I add to that? I want to agree with Israel, and I want to suggest that part of our mission is, of course, educating the clinical community in embracing evidence-based treatments. And that's at the interface of clinical care and research. So perhaps the research networks can collaborate with the other members of the consortium and use some of those funds to put together, as Israel has suggested, a more rigorous evaluation process of the programs and their evaluation and treatments, and actually come up with some publications that we could all be proud of, that could be disseminated.
Okay. I think for today, what I need to do, and I understand that, I also want to make sure that I'm fully aligned with the legislature on how they want us to spend the dollars that they entrusted us with. If I can approve this part of the budget, I can go back and talk to them. But again, the direction that I've gotten is a pretty firm line between the research component and those clinical components. We can talk about evaluation. I can go back and think through that with them. But I need to talk to them before I approve that in order to make sure that we, again, are in a very solid foundation of legislative support as we go into the next session.
I'm not against approving whatever we're right now. I'm just saying that there is a very firm foundation. If you look on evaluation processes, including American Evaluation Association, as well as other public health school work, that demonstrate and clearly argue that RCT, randomized controlled trials designs, are part of the program evaluations and normal program evaluation process. So I think if we just think about that in realizing that there is a transition between those processes, and the research is not fully divorced from the program evaluation and so on. In the future, maybe the next step we can think about, or even whatever is left over, you can work on that with the legislation and see whether they will be willing to accept that. And as I say, even the institutions that do programs evaluation, for sure, they will be able to testify that that's that they involve direct research. So.
Any other comments? Okay, so Michelle, you want to move to the
I
next?
had a question, Dr. Lakey.
Yes.
I was hoping to ask if the TRAYT storage cost, was that like a one-time fee or is that an annual recurring fee?
Michelle, you want to, and so I can jump in, and then Michelle, you can jump in. I think one of the solutions that Michelle and our team have looked at is that there is a yearly cost, but we can use one-time dollars to make sure that we have purchased several years of that one-time cost for those items, so that we're not having to, so that service will be there available for the next several years. Michelle, you want to jump in?
Yeah, I'll just add to that. So Baylor as the COSH has a certain amount of recurring dollars already. And so they would be expected to cover those costs year over year. What we're doing is we're purchasing some additional storage because there are some unknowns in terms of volume of records that we're expecting to have over the next year. And so this is a buffer for us to be able to pre-purchase some of those to make sure that we're able to cover the capacity.
Thank you.
Mm-hmm.
And David, just one comment, not to belabor the last discussion, but I do recall months ago that I think you had mentioned that there was program evaluation funds. So there is program evaluation going on, isn't there?
There is overall evaluation. That large contract will evaluate overall the consortium as a whole. We're spending $750,000 for that overall evaluation of the consortium as a whole, in addition to the internal evaluation contract that we have. So there is some of that evaluation. I think what others are asking for is kind of a additional type of evaluation. And again, before I approve that, I need to make sure that legislators would support it.
I think one small point I'd sort of favor what Israel was saying. I think there is a number of aspects of what TCMHCC is doing, where whether it worked or not, whether it was helpful or not, are kinds of program evaluation, which is a little lot more different than an overall program evaluation.
Yeah.
Maybe worth considering, but I understand what Dr. Lakey is saying.
Okay. So Michelle, you want to explain this slide?
So this is just a roll up at the program level of what the LBB originally approved, what our new forecast is, and then it outlines if any additional recurring funds or one-time funds are being added, and then what does that final cost look like and that final total percent change look like across each of the programs. And then I've got the last column, which is expected unspent funds. So the difference between what the LBB originally approved and what we're forecasting that final cost is going to be.
Dr. Lakey, I have one quick question. With the budget that we are considering, what are the total biennial ongoing costs at the end of this? In other words, what is going to be our FY 22-23 request to maintain ongoing services?
That's that final recurring cost column in the black there. So that 57,791 thousand is what those recurring costs would look like. It does not include what we would be asking for in terms of additional CAP fellows for the new programs that are being stood up. But that's just looking at what we have right now. That's what those annual costs.
One clarification there, Lachelle, for the final recurring costs would be the 57.8.
Mm-hmm.
So we're going to be looking at the next session for right around 115 in order to keep us at a steady state. It's not 2 times the 88. It is 2 times the 57.8. Right?
Yes, the recurring cost one.
Thank you.
Michelle, Dr. Newland's question about storage fees brought to mind a due diligence consideration that we be sure that whatever contractual language we end up with TRAYT foresees the possibility that the business may be sold, may fold, and so forth, and that whatever storage system or protocol we end up paying for is either with a third party that we can access, and so on, just to make sure that we don't have all our eggs in one basket of TRAYT.Inc.
Yeah, I know Dr. Williams is working with TRAYT right now to expand the contract. I don't have those contract details, so she would have to speak to that.
Yes, we do have in the contract that it's written that it's our data, that we have access to it. If and when we no longer are working with TRAYT, that data comes to us in a format that doesn't take us 500 years in the Da Vinci Code to unravel. So those were things that were built into the contract.
Would there any consideration to having duplication on a third party, kind of an archive that would be updated regularly, so that in their worst case, we're not beholden to them to make that access possible?
I mean, I think one of the things that I would recommend, Laurel, when you are negotiating with TRAYT on that is perhaps the storage that they do. And you mentioned the cloud. Perhaps what they could do is store it on one of the larger companies like Microsoft or AWS. So that way they are, they spin off an instance of our data on that storage with us having access. So if something happens to TRAYT, it's still there and we have access to it versus, dependent on TRAYT's private cloud or whatever. And so
I believe it is
not,
AWS.
Yeah, it's not TRAYT's private cloud, it's AWS.
Yeah.
Okay. Yeah. That's exactly what I had in mind now. Thank you.
Okay. Any further discussion? All right. So I want to flip back, Lachelle, and we'll take each of these in order, but I thought it would be important for you to see the entirety of the changes before we approve the individual. And so we have this recommendation from our staff to use the recurring funds in the way that's allocated here to expand CPWE to additional local mental health authorities in the Valley and to expand some additional CPAN capacity at UT-RGV. So let me approve these and then we'll go to the next items. Is there a motion for approval?
I move approval.
Second.
I have a motion by Steve Plitzka, a second by Dr. Tominga. Okay. All right. Any further discussion? All in favor of using the recurring funds to fund these items that are on the slide, signify by saying aye.
Aye.
Aye. Okay. All opposed, signify by saying nay. Hear none. All that are abstaining, please signify that you're abstaining. Okay. We have approval, unanimous approval to use the recurring funds for these three items that are listed on this slide. Okay. I have a reminder from David Lean to make sure that we are making public comments publicly. And the people that are watching can't see the chat functions. So please make sure that we are, raise your hand and I will call on you. If I don't call on you, let me know, but we'll make sure that everyone gets to hear the comments and the discussion that's taking place in accordance with the Open Meetings Act. Okay. The next item of business, we have these proposals related to the COSH to buy these additional services statewide. You can take a look at it. After you've taken a look, I need to have a motion and a second.
Motion to approve it, Jeff Matthews.
Jeff Matthews,
Second.
motion.
Second, Karen Wagner.
Karen Wagner has the second. Any further discussion? Hearing none, all in favor of using these one-time funds to buy these items as listed on this slide signify by saying aye.
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 Okay. All opposed signify by saying nay. Okay. Anyone that's abstaining, please identify that you're abstaining. I hear none. We have unanimous approval for those items. Third item that we need to vote on is using, again, the additional one-time funds to do the items that are itemized on this slide. Take a second to look at this. Okay, I will need to have a motion and a second.
So moved.
Motion.
I have a motion by Dr. Nemiroff, a second by Dr. Polowitz. Any further discussion? Hearing none, all in favor of approving these items in this current fiscal year signify by saying aye.
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 Opposed, nay. If you're abstaining, please identify. Hearing none, we have unanimous approval for these items. One item, just to be clear to the audience that's listening besides the executive committee, is for the cost, it does bump up the amount of money beyond that 10%. We think it's still, though, very germane in that we're purchasing things as a whole versus an individual institutions. So it meets that intent of being below 10%. But we will be transparent to the LBB, and we'll send a letter to the LBB letting them know about that. And then if they have any further questions, we will have those conversations. And if the LBB says that they would like a letter for approval, then we will submit to that. But our intent right now is to send a letter of information to them and get their guidance. Okay. Michelle, is there anything else on that we need to discuss?
No, I think we covered it. Since these have been approved, next step will be working with each of the HRIs to amend their PIAs to reflect the new budget amount. We're also hoping to change how those budgets are reported. So we'll be updating the contracts to just make that more clear.
Okay. Very good. With that, I believe we've completed all the business of the day. Luann, is that right? Is there anything else that we need to discuss?
That's it. That's all that's on the agenda.
Wow.
Very, very good.
Very quick, coming back to CPWE, HHSC needs an identified contact for the the distribution list, who they'll send it to, i.e. the lead for the CPWE at each site, who you want that to go to. Obviously, they also need to send it to COSH and whoever needs it centrally. So if people could send me that information, I'll get it on to Sonia as quickly as possible. Or send it to me and Luann, actually, it would be best.
Okay. Sarah Martin, I see your hands up.
Hi, yes. So as part of our CPAN engagement, we have started a child psychiatry grand round series that's on WebEx, which is, something like Zoom. And so we're hoping that many of the child psychiatrists in the audience or psychologists or therapists at your institutions would like to be invited as a guest speaker. So if anyone's interested, this program will provide free CME for anybody who logs on with their email address. So you can send it out to all the PCPs in Texas, and we have prepaid up front. So there's not even an extra cost to each institution. So we would like you to be, and it can be also trainees. If you have a trainee who's a good speaker, I already checked ahead of time. It can be, as long as it has something to do with child psychiatry, we have it, you're under the scope and people can get their CMEs. We'd also of course, everybody probably knows that ethics CMEs are highly attended because they're required for a Texas license. Well, most licenses in most states, but that's one way we can get more participation from primary care providers. So the series is called Child Psychiatry for the Primary Care Provider. And we've already done depression, anxiety, and ADHD, but just the very basics. So we wouldn't want a real basic lecture on those, but even an more advanced lecture on ADHD, depression, and anxiety is fine. But really, any topic is up for grabs. So just email me and we will schedule you. We are trying to do them at lunchtime on Thursdays and Fridays. But we are flexible. We just have to let the CME office know that we're changing the time so we can change the flyer. It's very simple to adjust and add a new speaker and all that. So might be good too for some of your more junior people if they need invited talks. It's something they can put on their CV. So let me know and I'll put them on the schedule. Thank you.
All right.
Dr. Martin?
Sarah, what's the calendar you're looking at? How far out are you scheduling?
We have prepaid for an entire year, so it's the fiscal year.
Okay.
So from now until next August, we're scheduling.
So for a number of people, it's difficult to do. Certainly for me, before the end of the year, but come 2021,
Yeah, we're scheduling all the way until next August. And really, you know, we'll probably do it next year too if it's at all successful.
Sarah, this is a fabulous idea. I'm wondering whether you can keep all of these grand rounds talks and we can repurpose them at other sites and other centers. It would be very good if you could share them around.
Yes, so
we'll offer to help.
Yes, I've been working with Daniel, and so as soon as we have them recorded, we are going to give them to him to post on the website, on the consortium website. And then also we hired a company with part of our funds that we're using for engagement. We hired a company who is actually going to come and do some professional recordings. So we'll have the recordings of the live webinars, but we'll also have that. And then anybody who would want to give us permission to translate their material into a module through Canvas. Canvas is like Blackboard. It's used by colleges for online classes. So we're gonna, every topic that we do a live webinar, we're gonna translate it into Canvas, and our institution already has a license for Canvas. So we are just paying an extra fee for a certain amount of users. So we can, so up to 100 extra people can view those modules. So it's basically a way of getting CME on your own time, and it's a more interactive way. You'll watch a video, then you'll answer tests and have a little pop quiz, that sort of thing. So that'll be coming later on down the line.
I'm sure you'll get volunteers from the Depression Network and from the Trauma Network.
Yes, I hope so. I hope so. Thanks, everybody.
Sarah, one more question, please.
Yes.
Refresh, is the target audience primary care or also?
Mostly primary care, but if people wanted to do that, because that's the name of the series.
Okay.
But we have our regular psychiatry grand rounds too. Yeah. So if somebody had something that's really only appropriate for a Department of Psychiatry, but they would like to be part of our grand rounds at Texas Tech El Paso, then we would love that too, because we're always looking for speakers for that also.
I asked because ACAP, is going to be all virtual, but in fact, most of the main things are being pre-recorded. So we could kind of scour those and see which might be appropriate. And of course, those are already pre-approved for CME.
Right.
We're thinking about looking over the program.
That's a great idea. And I still wanted to work with you, Joe, on, I need the, remember we had talked about the document that is PsychoFarm in Texas, and it started as started as targeted toward people who care for foster kids, but then it kind of expanded.
Simplifying the parameters. Yeah, let's follow up on that, Sarah.
Yeah, that's something I'd love to, that HAC, I guess, is in charge of now. Is that right? And so we want to post that on all the websites too.
Yeah,
So.
I'll send, that's actually the one I'm going to use as the foundation of the TChat manual. So I'll send that link around and a PDF of it as well.
Yeah, I'm hoping that we can maybe work with them to make an abbreviated version, because that one's super comprehensive, even with discussing off-label antipsychotics and that sort of thing. So maybe one of the ideas I had to engage primary care providers to make a smaller manual that's more basic. So if anyone wants to work with me on that too, that'd be great.
Sarah, is what you're doing, is that, I want to make sure we don't get an overlap, because there's the CPAN, the TChat thing, I think started out also as somehow overlapping with CPAN. Are you thinking of doing the same thing in terms of a psychopharm manual? I mean, how
The psychopharm, it would be more developing, it would just be more that document would be, I wanted to kind of simplify it so that a primary care provider would be more likely to read the whole thing.
Well, actually, that's sort of what I had in mind.
Okay.
So we may be moving toward the same goal here.
Yeah, let's work together. That sounds great.
Okay, that'd be fine.
And Dr. Martin and Dr. Pliska, I have used that foster care manual as the basis of several different education presentations to primary care physicians out here for depression and anxiety and ADHD. So I'm happy to share those slides with you guys and see if that's helpful.
That would be good as well.
Yep, that'd be great. Thank you.
Dr. Newland has patiently waited while her hand's up. I guess one quick reminder, even with the questions, we need to make sure that it's germane to the agenda that we put out. I think that last conversation is germane because it's related to education of primary care providers and part of CPAN. But just, again, there's a couple of hands that are up for questions, and make sure that we pull any of this conversation into the items that are on the agenda. Okay. So Dr. Newland?
Thanks. I think Dr. Martin might have answered my question, and I'm not sure how germane it is either, but
okay.
All I wanted to know is who made the professional videos that had been mentioned previously. And I think that might be you, Dr. Martin.
Yeah, we haven't started with that. I think we're starting that in mid-October. So they aren't developed yet, but we hired an advertising company that Texas Tech El Paso uses for different events around town. And so I'll let you know how it goes. We'll see.
All right. Any other questions or comments related to the
Luann.
items that we've covered today?
This is Luann, and I do have a favor for Dr. Martin. If you could summarize all of the information that you just spoke about so that I can send a reminder out to the executive committee about it, that would be wonderful. Thank you.
Right.
Sure will. Thanks.
Dr. Lakey, this is Sonia. I have a resource that I thought of that could also be of help for CPAN and TChat. HHSC got notification on Friday that we received an additional $20 million that will allow us to continue providing COVID-19 support through our local mental health authorities. So again, that is another resource that we can, that again, this group can tie into. For access to those services, people can either go through their local mental health authority or call the mental health COVID-19 support line. That number is 1-833-986-1919. Again, those are crisis counseling services available for people that are affected by COVID-19.
Okay. Any other comments, questions? If not, we can entertain a motion to adjourn.
So moved. To adjourn?
Okay, I heard Dr. Pliska, I think Jeffrey Matthews. Any further? All right, all in favor of adjourning signify by saying aye.
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 Opposed, nay. Hope you all have a great week. Thanks everybody for your time.
Take
today.
care. Bye-bye.
Thank you.